You are listening to the Addiction Files, where we discuss evidence-based treatment, clinical pearls, and resources while striving to destigmatize the treatment of addiction in our medical culture and save lives. We are the Addiction Doctors, Dr. Darlene Petersen and Paula Cook. Welcome to the Addiction Files. We are thrilled. We have Dr. Spencer Hansen joining us, and we are discussing therapeutic tools essential for addiction medicine. And this is a topic that I am really excited about. And I'm going to turn it over to Dr. Hansen to first introduce himself to us and then explain this topic to us a little better.
No, thank you, Darlene and Paula. I am an addiction psychiatrist. I work for Intermountain in Salt Lake City. And previous to that, worked as a crisis care or emergency psychiatrist, also with Intermountain, for about 3 to 4 years before deciding to pursue a fellowship in addiction training, where I trained at the University of Utah with Beth Howell and faculty, and fell even more in love with this space, working with folks who are trying to improve their lives around addiction and drug use. And I've got 4 kids at home. They keep me busy when I'm not at work, and really enjoy trying to pursue work-life balance. And I feel like work-life balance comes through when I'm attending to patients in a way that is meaningful and also valuable. And I think about this topic all the time, as I'm sure you guys do too, and all the listeners, as you drive home after a hard day of work, you're like, I could have done better there in clinic or in the hospital. But there are times, they're not often enough, where I drive home and I feel peaceful or just content with the work that happened. And as I reflect on when those times are, it's usually when I'm attending to 2 particular therapeutic skills or interventions. And those 2 tools are listening, which you could maybe even call as like a procedure. Maybe even the most common medical procedure in medicine is listening. And also in safety planning or crisis planning. Some people might refer to that as like a stabilization plan, if safety plan or crisis plan doesn't sound healthy enough for them. You know, they call it different things, but essentially having a safety plan in place when people are having thoughts of suicide, self-harm, or drug use. And so I've noticed in my personal practice, as an outpatient addiction psychiatrist, that if I really focus in on listening to each patient and spend careful time, especially if they're higher risk of return to drug use or self-harm, of discussing with them openly about their suicidal thoughts, and using that discussion to write down on a 3x5 card a safety plan or a crisis care plan. And I may get the medicine wrong that day. I may not hit it exactly on the head with other therapeutic maneuvers. But if I feel like I'm listening and I feel like we're talking about the safety plan, it's usually a good day in the clinic, because I can kind of sleep more peacefully that night. We can adjust the medicines moving forward down the road, but if I don't listen and if I'm not attending to the safety plan, I think that's where you lose sleep. And I think a lot of us experience that as well.
Yeah.
So I think, as an addiction psychiatrist to the psychiatry profession, I'd like to start us off with a observation or a meditation based on the Hippocratic Oath. And what I'd invite the listeners to do is just kind of sit back, close your eyes if you want, and lean into these words as we recall the Hippocratic Oath from medical school. And so I'll read that out loud as we reflect on this oath and what we committed to a long time ago. So I swear to fulfill, to the best of my ability and judgment, this covenant. I will respect the hard-won scientific gains of those physicians in whose steps I walk, and gladly share such knowledge as is mine with those who are to follow. I will apply, for the benefit of the sick, all measures that are required, avoiding those twin traps of overtreatment and therapeutic nihilism. I will remember that there is art to medicine as well as science, and that warmth, sympathy, and understanding may outweigh the surgeon's knife or the chemist's drug. I will not be ashamed to say I know not, nor will I fail to call in my colleagues when the skills of another are needed for a patient's recovery. I will respect the privacy of my patients, for their problems are not disclosed to me that the world may know. Most especially must I tread with care in matters of life and death. If it is given me to save a life, all thanks, but it may also be within my power to take a life. This awesome responsibility must be faced with great humbleness and awareness of my own frailty. Above all, I must not play at God. I will remember that I do not treat a fever chart, a cancerous growth, but a sick human being whose illness may affect the person's family and economic stability. My responsibility includes these related problems if I am to care adequately for the sick. I will prevent disease whenever I can, for prevention is preferable to cure. I will remember that I remain a member of society with special obligations to all my fellow human beings, those of sound mind and body, as well as to the infirm. If I do not violate this oath, may I enjoy life and art, respected while I live and remembered with affection thereafter. May I always act so as to preserve the finest traditions of my calling, and may I long experience the joy of healing those who seek my help. That was a meditation I kind of wanted us to experience as we reflect back on the Hippocratic Oath, and wanted to see Paula, Darlene, what stuck out to you personally, listening to that again.
Well, I thought that was really wonderful. Thank you so much for sharing that. For me, what struck me immediately is how protective that exercise was for like burnout. Just like remembering what it's all about and like what we promise to do and what our calling is. I just love the exercise in and of itself. I'm like, man, we should do this more often because you're so excited coming out of medical school or like the white coat ceremony. And then once you're in practice, we don't often get the opportunity to remind ourselves of like really what it is we get to do and why we're doing it.
Yeah, I love that.
Yeah, I almost couldn't say that better, Paula. But I do. I think it helps to remind us about it is just treating the whole person. And back to what you just started with, Spencer, just really our ability to connect and just the empathy with that person that we're connecting with. And like what Paula said, just that, especially when we start thinking about burnout, it's when we're losing that connection. It's all about that connection.
Yeah, no, that's just, saying that sympathy and connection and concern can be more powerful than like a procedure or medication. And how true is that? Just having someone to listen to you and that you can trust and just having a safe space can be so therapeutic.
And I feel like as clinicians in addiction medicine and addiction psychiatry, we all have that opportunity to improve our um, ability to sit with someone and ability to listen. And that using listening as a tool and as a procedure is something that we can craft and refine over time. And I definitely don't approach this topic assuming any sense of mastery. And I hope to continue to learn how to listen and how to safety plan with people like through the rest of my career. And I think that having that perspective actually takes a lot of pressure off having to get it right now. And hopefully for all our listeners, your ability to safety plan with people and your ability to listen if you don't feel you're at your strongest, it's not no one's expecting you to be at your strongest right now, but you have an opportunity to grow and in that skill and that procedure in that intervention. So I work with residents. They come and rotate through the clinic where I work, residents in medicine at the University of Utah. And so it's sometimes a bit of a shock when they're used to working long nights, on call or in the wards or in the ICU, and they come in and there's like this really relaxed flow to the outpatient work. And I'm not necessarily like jumping in with the stethoscope at all or doing physical exam maneuvers, but I talked to the residents about like this rhythm is going to be different, and we're going to be focusing on listening to the patients. And I always talk about how listening can really be some of the best medicine actually that we can offer patients. And there's someone who I look up to as a mentor in emergency psychiatry, John Berlin, and he has worked as an emergency psychiatrist for many decades. And he talks about how the interview is the treatment. And if you think about in the emergency room, with how that feels in there and all the noise and the fast pace, if you give someone putting your pencil, paper down, 5 minutes of undivided, attentive listening, 3 out of 4 times you can resolve the crisis in that 5 minutes. And this is coming from someone who's been in the emergency room for decades. And I found that comment from him was very powerful and made me want to learn how to listen better, because if listening is the intervention and you can do it in 5 minutes of undivided attention, which for patients, undivided attention for 5 minutes might feel like 5 hours to them. When's the last time someone sat down in their life and listened to them for 5 minutes, uninterrupted, 100% attention on them? There's incredible just relief and sense of calming that can come from that. Oftentimes, assuming they're not in a significant state of withdrawal or psychosis or mania.
When you talk about like just listening, Spencer, tell us if this is more like active listening? Is this, and what kind of nonverbal behaviors do you display? Like how do you really engage with your patients in those kind of situations?
I think how I engage and principles of listening, which there's some literature out there that describes how we listen and how we can listen as clinicians and as therapists. There's a lot of literature out there, and some people refer to it as attending behavior, which I think fits well, for those of us who are attendings. And
I think that's such an interesting word in the first place, isn't it?
Yeah, it is. Attending to the issue at hand or the person in front of you and kind of holding a safe space for them. So how we attend to them can really influence if they're going to speak up openly and freely, or if they're going to close up and not have an exchange of ideas in their head or what they're feeling. And so I think to start off with the principle of listening is I always try to remind myself that it's not about finding the correct thing to say. And whenever we start off thinking that we have to find the correct thing to say, sometimes it can inhibit our ability to listen. Because whether we're nervous about the next thing to say, or, looking at the clock, or trying to say something to somebody that we've said to someone else in the past that worked, might not necessarily work for this person. And so some of the best advice I got in psychiatry training was, if you don't know how to start, just be curious and let your curiosity guide the listening.
I love that. That's great.
Can you elaborate on that a little bit? So especially, I think that makes a lot of sense in terms of like the interview itself, like be curious with open-ended questions, but how do you do that with listening, like curious listening?
I think one of the things I've appreciated in the literature on this, and how to avoid maybe negative attending behavior or anything that closes up free and open dialogue, would be to try to avoid those things that we do often when we're not thinking, such as like excessive head nods, like, or saying, too much, or even too much eye contact. You can be very intentional about how you use eye contact to help somebody open up. And there's a lot of, things that we learn in motivational interviewing, from Miller and Rolnick, and those kind of attending behaviors that work. But I think their approach is always to use those in balance with motivational interviewing. And sometimes, in order to encourage someone to keep talking, we might repeat their last word or their last phrase, but making sure not to do that too much, because it can sound robotic and it can make someone annoyed and it can close them up a little bit. Or if we're excessively mirroring their stance or their the way that they're sitting. And I heard, long ago, never fold your arms across your chest when you're listening. And I'm always surprised at how much I violate that in the clinic. And every time that I do, I'm like, I wonder if this really is closing somebody up. But I definitely feel like a barrier happening when I fold my arms across my chest. And so just those little nuances that you can pay attention to from visit to visit and reflect back on, which is easier to do if you have a somebody shadowing you, like a resident or a medical student. Like, how did I do there? I have too many like excessive head nods, too much eye contact. Did you feel like I was listening in a way that this person opened up more? Or was my approach maybe not as helpful for them to open up? And that's important to review from patient to patient or encounter to encounter, because a lot of the research shows that, communication is 90% nonverbal, 10% verbal.
I'm like a head nodder, so now I'm nervous. Like, now I'm going to have to start counting when I'm talking to patients.
That's so funny. Me too.
So here's the advice for you, Darlene.
Yes.
And again, not that I'm a know-it-all, but this is advice I got back in psychiatry training. Actually, your next encounter with somebody, you cannot head nod one time.
There we go.
Okay. And the intent of that is to make you feel very uncomfortable, and to also recognize, how your head nods may be occurring in your patient to patient interaction.
Yeah.
And I've tried this too. Like, my challenge from my attending in residency was, okay, you cannot say or I see or yes after somebody says something. And it was incredibly uncomfortable, and in fact at times awkward, when I felt like it deserved like a or I see. But that intentional exercise can help us be mindful of how we're using these behaviors in our listening. And maybe don't try it out on a patient. If you want to, try it out with someone at home, or try it out on a friend. That might be a safe place to do it, where you just don't.
I look less like a statue.
Frozen. That's going to be a really interesting exercise. I'm going to try that.
I am too.
Yeah. That's what's really cool about this is I'm so glad you're bringing these tactical skills, because neither Darlene nor I, and many people are not trained in psychiatry. We don't get any of this kind of training. Even in addiction medicine training, we didn't get any kind of useful training like this, other than motivational interviewing training. But I don't think we went into the real granular details of like body language, nods and body language and that kind of thing. So this is so interesting. I'm really want to know what you're going to say, and maybe this is coming down the line about documenting while listening, because this seems to be my biggest challenge, especially when you're taking a very detailed history, and you can't, like, I don't rely on my memory enough to remember every single detail. How do you document and listen well?
Well, I'll just give you what I'm currently doing, and it'll probably look different in 10 years. Hopefully it does. But as you know, I took John Berlin's advice, the guy who's been at this for decades in the emergency room. And so he said, okay, you give someone 5 minutes of undivided attention, it'll feel like 5 hours for them, and you will help them calm the crisis. They will feel listened to. And so I take that 5 minutes into my outpatient work. So for the first 5 minutes, I'm very intentional about no notes. And it's just full undivided attention. After that 5 minutes, I pick up the keyboard or I pick up the pen and I start to take the notes. Because I feel like at that point, they are locked in on the fact that that first impression is like, this person's listening to me. This person is really understanding. And I really don't feel like that picking up or starting to type after that 5 minutes or picking up the pen is negatively impacting the attending behavior. I think people just naturally recognize that, like, yeah, there's a lot of information here. So this clinician is starting to take notes now. So that's my current approach. And it gives you a chance to just like relax a little bit because you know how many notes you have to write that day. But you have a gift now. You can, for 5 minutes, not have to write any notes, and you can just focus on that important procedure of listening and counting your head nods while you listen.
Love that. That's great. I really like that. And how wouldn't that be lovely if that's all we had to do? Is not have to document, like don't have to take notes at all. But like you said, things may look very different even a few years, because I know there are some apps and stuff that will write your notes for you. But okay, thank you for answering that.
Yeah, and I think a tailored artificial intelligence in this particular situation that is understands Darlene and Spencer and Paula enough and how we use words. 10, 15 years from now, maybe we're at that point where there is no typing, there is no note taking. It allows us to be present and attend the majority of the encounter, which I think is something really exciting. And talking about burnout, something to look forward to as we, move forward in medicine, minimize the documentation burden. And something else I think that can really help, as you talk about, you didn't go through that training that maybe psychiatry did. One of the best things that I learned that I try to talk about with the residents and medical students is it's very natural for even the best listeners to not do it well. It's very natural. It's very natural for the best listeners to get bored and distracted. And that took a lot of pressure off me to hear that, because, it helped me remember that we're all human, even clinicians. And while we try to live up to those impossible ideas of the Hippocratic Oath, we're not going to. It's just ideals to live and work towards so that we really can become the best we can for others and for the people that we work with. And so that takes pressure off. So you don't have to find the right thing to say. That's not our job. And it's okay if we get bored or distracted during those 5 minutes. We just want to keep working on it from patient to patient or from client to client.
I love that. And I think, I don't know, personally, some of the best reminders are when I'm a patient myself or when I'm with a family member who is a patient. And I realize how important it is to have someone who's just at least trying to listen, especially when it comes to sensitive things. And you become acutely aware of being on the other side of the table. And you really yearn to have a provider just stop and listen and take care when your loved one or you are telling them something really important. Yeah.
Yeah, and these are the most intimate details. Like sometimes aren't you both surprised at the things that we hear? Like we hear things that people don't share with anyone else. It really is a kind of almost a sacred space that we are in as we do this work, because it's just very intimate and sensitive information.
Absolutely.
No, it just amazes me when you brought that up, that how many patients, and Paula, you would attest to this too, that they wait until their appointment with you and you're the person that they're going to come in, and sometimes it's not just always their lows, but their successes and things, that you're the person that they're going to come share that with. So it's like you said, it's that ability to really connect and listen.
And I know with that, as they wait for you and for us to come see us, and all of our listeners probably hear this every now and then, but they carry the conversations with them until the next appointment. And that really, I think, is where it becomes almost like ongoing medicine for them. Those conversations are medicine because they can reflect on them, they can remember, and they can prepare for the next encounter as they go about their day to day, just whether it's just trying to survive or trying to make that next big decision for their job or for that move, or what the next thing is that they're thinking about. And kind of back on that idea of when you don't know what to say, a couple of authors, Meyer and Davis are their names, back in 2001 wrote a paper, and they recommend when you don't know what to say nothing. And this will be important at times in safety planning or crisis planning, because it's not our job to come up with that content for the safety plan or the crisis plan. People are working it out in their head, and we provide that assistance as they're working it out. And so to get really comfortable with the pause, and in particular, when people start crying in the office or in the hospital, we might sometimes be a little too rushed with saying something, when really we should let them work for 20, 30, 45 seconds while they cry with us not saying anything. Even handing a box of tissue is controversial in my field, because it can send that obvious signal to them to stop crying. I'm uncomfortable when you're crying. And so have tissues in the room, but don't offer it to them. Because that can be again just a message that's like, please, here, take this tissue, stop crying.
Like, wipe away your tears, make it stop. That's really interesting. I'm doing it all wrong. Like,
I don't know if you're doing it wrong.
Because you're taught, like, don't ignore, you want to attend to their needs. So that's so fascinating. Yeah. Darlene and I had the same attending in residency who was particularly good at being quiet. And he would just let people talk. And it was amazing what people would say.
Oh, yes.
He would just wait, like the most awkward silences. And I'd be like sitting there as a resident going, oh my gosh, would you please say something back?
Like, I would be sweating. And
yes, you know who I'm talking about. And then the person would just talk more and more. It was such a good learning experience for me to witness that style, because I'm so chatty. I was like, just want to keep talking. So that's excellent.
I want to get to know that clinician, that attending of yours. I just think, because remember, people are working it out in their head. They're doing therapy. They're doing the work right there with you. So in a sense, the medicine is taking effect when we listen and when we allow them to work it out in their head, especially during the crying. Now you'll get to that point where it's like, okay, then 45 seconds, I'm going to say something, just to let you know that I'm still here and I'm attending. And maybe that's you hand them the tissue at that point. But yeah, try it out. Next time you want to hand them the tissue, intentionally don't, and just see how you feel.
I've got some assignments. I'm like, wait to hand the tissues. No head nodding.
Oh, there's this quote that I captured from a follower of Confucius that I loved as I was preparing for this podcast episode. And the quote is, or more of a Chinese proverb: stillness and tranquility set things in order in the universe. The stillness and tranquility set things in order in the universe. And I really kind of believe that the more we can provide that for individuals that are coming into our space with their chaotic lives, especially with what addiction does, and the more stillness and tranquility we offer through our listening, and the less that we rush into an answer or to help them work through their medication treatment plan, I think we can help people have a good experience. And I think my bias is that, again, the listening really is some of the best medicine that we can give.
I'm not in agreement.
You're getting your practice in right now. So I think some of the other listening tools that we read about a lot again in motivational interviewing and other books on how to listen, are still very important, and those include things like paraphrasing. And I think the important point I wanted to share on paraphrasing, which I have to remind myself often, is it's not our goal to add to or take away, and it should be brief and accurate. But it takes again, like a lifetime of practice to get the paraphrase right. And I think Miller and Rolnick, even in one of their editions, they wrote that it's very easy to do poorly a good paraphrase. It's quite challenging to do it well, and that caught my attention because I think the paraphrase might come off as one of the easiest maneuvers to use to demonstrate that we are listening. But if they say that it's quite challenging, then I better be paying attention to how I paraphrase.
I think that's so true because patients, you can immediately put them on the defensive if you do it incorrectly.
So are you ready for another homework assignment?
Yes, I can use lots more because you're probably like, you're doing it wrong still.
No, and by the way, these homework assignments are for all of us. And an invitation is out there for all of us to keep practicing throughout our careers. And not just in our careers, but with our loved ones and whatever. But so there's actually is in neurolinguistic programming research, work that has been done to show that empathy and trust and desire to follow up with clinicians increases when we match our clients' representational system, their sensory based representational systems. So pay attention to the next person you're working with, the next person you meet in your setting, your clinic setting, and listen to how they're talking, their sensory system, because people will use usually one of three. They will either see things like, the way I see it, it looks like that car is red. Or they will talk about how they feel things. The way I feel when I drove in that red car, I was very moved with the acceleration. And they're a very feeling based representational system in their head. And then there's the person who hears. And like, what? When I hear you talk about red cars, it sounds like all you care about is red cars. And for them, their representational system is hearing. So people either see with their representational system, they primarily feel, which is more of kind of like a kinesthetic, like movement dialogue in their head, or their auditory. Like I hear, it sounds like, so visual, auditory, kinesthetic. And you can try to pay attention to what your people that you're working with, what representational system they use. And if you match your dialogue with theirs, there's even research to show that there's increased empathy and trust in there. And
That's
I think that's
fascinating. I love that.
So and it really, you can use that as you transition into safety planning or crisis planning. Use the representational system that is core to them in their head in the dialogue you use with them with safety planning. Yeah. So after the paraphrase, we try to use summarizing too. I feel like motivational interviewing really helps prepare us on how to create a great summary and to provide that. Like I think they use the metaphor of like a bouquet that you hand to people of, all their desires, abilities, reasons, and needs to change. You just like summarize it back to them and hand it to them. Complimenting, the idea of complimenting someone in the office, I think it's important to highlight there that that's not listening, and it's more your opinion or your taste or your approval of that individual. And so if we're complimenting people, just remember that's great, but it's important, I think, in balance, but it's not listening, because then we're interjecting our own opinions or approvals. Um, and so that's important to remember. And reassurance too. Reassurance is not necessarily listening, and it can at times be counter-therapeutic. So when we offer people reassurance, at times and that in particular would be when the reassurance takes responsibility off of them. And I feel like in fellowship training, I was exposed and around a lot of attendings, including like Steve Sugden, who's been a guest on your podcast, who reminded me often, like, anything that we do, we don't want to enable people as they're working recovery. We want them to slowly grow into a sense of autonomy and responsibility. And so maybe like too much or false reassurance can take responsibility off them. And so you want to still reassure, but just make sure you dose it in small, infrequent, like, amounts, small infrequent amounts. And complimenting and reassurance, we're not talking about empathy. And when I talk about like empathy, like, be very liberal with empathy along the way. Do not ever feel like you should shirk empathy. It can only build, trust and rapport.
Wow, that's really tricky. And like in terms of, I'm thinking practically about people I even saw today, the wide gamut of people who are like really stable, seem to be doing quite well, functioning, to people who are actively using, struggling with the judicial system, custody battles with their children, and trying to empathize with those folks without reassuring and therefore like enabling maybe, and then still maintaining kind of this harm reductionist model where you want to meet them where they are, not be judgmental. I'm trying to think of how I can improve on that. Do you have suggestions with a particular like scenario like that?
Mm. It definitely not any suggestions or experience, Paula, that I feel would be more useful or accurate than what you're already doing. Um, as I talk about these things, I'm mindful of the fact that I have a lot of improvements to make myself. But and so I respect the work that everyone's doing already, just in this space. Again, I don't think I'm better than anyone else. But one thing that has helped me, Paula, with that, as I work through the spectrum of where people are in their healthy living, is just try to think about the metaphor of like, how much hand holding does this person need right now? And you see it often in the emergency room, right? Like, people need their hands held for 2 weeks or 2 months before we can start letting go of the hand holding and offering less reassurance, or less enabling maneuvers. Because you'll have someone walking in there who's late, and you will not confront them about their lateness, because if you do, they very well could go home and hurt themselves because they're in a very bad state of mind, versus someone who you assess as more stable, more resources. Their lateness is causing now a negative pattern of
Mm-hmm.
behavior and enablement, and you're gonna say, you know what, it's not okay actually that you're late this time, and let's talk about it. So you're putting the responsibility back on them. I guess that's what I would have to say about that. You're probably doing it beautifully, and much much better than I can do it, and I could learn from kind of the work that you're doing down there, and the scope of severity of illness that you see.
Oh no, I don't necessarily think that's true. We all have room for improvement, but that's really helpful. I think trying to just gauge where people are and maybe where their resilience is at that moment and what they need. That's an art, I guess, that we're all working on.
Yeah, and I think the Hippocratic Oath refers to that art, and so it's nice to hear that we can be staying true to that oath as we work on this art. And we'll feel like we got it wrong sometimes, and I think that's totally appropriate and okay. I guess in summary here with the listening, um, we want to promote those maneuvers that can free people up to an open dialogue and to increase empathy and trust. And we've talked about a few of those things tonight. Trying to match their sensory representational system, and allowing comfort in silence, and making sure that we pay attention to our nonverbal communication that maybe sometimes we get in a habit of doing a little too much. And that as we listen, we really set ourselves up to help the individuals we work with create a safety plan or a crisis response plan or a stabilization plan that can move the needle on saving a life and preserving a life. And I think that was the second tool that I really felt strongly I wanted to cover tonight with you both is, the safety plan and what it is, crisis response plan. So what do I actually, when it's my turn to talk, what do I actually say when I'm talking with someone in a crisis? And I'll share with you my growing understanding in this outpatient addiction psychiatry role, a growing belief that, and maybe you already believe this yourself, or it's a theory that you hold strongly, that anyone that's working through an addiction is suicidal to some degree. And so the question isn't, are you suicidal? The question is, how suicidal are you in your head as a clinician? Okay. So it's really kind of a pointless question to ask somebody, are you suicidal? They think about suicide. Suicide for someone going through a severe substance use disorder is a way to get out of the substance use disorder. And it's as legitimate as an option as getting on Vivitrol or Sublocade or long-acting injectables, naltrexone and buprenorphine. So now they may only be thinking about it like 1% of their day or 1% a week or 99% of the day. Our job is to figure out how much, because that's going to dictate how we talk about the safety plan with them. So again, I don't know if there's any way to verify that in a research study, but my theory is that anyone with a severe substance use disorder who's trying to get over it thinks about suicide as one of the options.
No, I would agree. I just think from our experience, but I think it's a hard one for people to admit because we sometimes feel powerless to do anything about it. So I think that's great. I think that's a really excellent point.
And that power, that sense of powerlessness is, I think it's an important internal signal that can help us stay humble. Because if we didn't have that, we wouldn't be on alert and we wouldn't be applying the intervention of the safety plan. Those nights where like you're not sleeping well because like you missed something with that individual.
Yeah.
The safety plan helps calm those nerves a little bit. So what do we do with that sense of powerlessness? And every time I have someone in the office who's, I think, is moderate to high risk of suicide or self-harm or return to drug use, I feel that powerlessness every time. I'm like, I have no idea what to say. So you can follow a format that's been shown in research to help save lives, and that's the safety plan. It's a crisis response plan. And a way to look at it is when you're talking about it with folks is in a metaphor I like to use that I heard from somebody else. It's CPR for mental health. So this safety plan that I want to talk to you about today, with you and with your loved ones, and this crisis response plan, it's kind of like CPR for mental health. It's going to help you have, simple steps to walk through that can help you choose life when you don't want to choose life right now. And so it helps the dialogue maybe start for them right there. And safety planning, it grew out of the CBT movement, which is the cognitive behavioral therapy movement, is where safety planning came out. And it helps someone like feel empowered again when everything is out of control. And so it helps someone identify, what are the events in your head or in your environment that are associated with your internal pain, your internal hopelessness. And once you help them identify those things and they write it down, then you move to identifying the skills or the tactics that they can use to reduce the sensations or the pain of, wanting to suicide, self-harm, or use drugs. And it provides easier access, I should say, than they normally would have if they don't have a safety plan that they've walked through. And the beautiful thing about crisis planning, safety planning is you don't even have to be a clinician to do this. It can be anyone from a teacher to a neighbor, a parent, a sibling, of course, healthcare provider. But the principles of safety planning anyone can use. And as you talk to patients and clients and family members about it, they will be able to share those principles with their neighbors, their neighborhood, the community. And so your ability to share these steps in a safety plan really can help a community get healthier and help a community choose life over death or sickness or addiction. There's great research out there to show that safety plans reduce emotional distress. When you make a safety plan with someone, just like listening, it's a treatment, it's an intervention. And just like, maybe a medication for anxiety can bring emotional distress down, creating a safety plan can bring down emotional distress. We know that it increases commitment to living and to treatment. And safety planning really facilitates appropriate use of crisis services. So you don't want to overuse crisis services. You definitely don't want to underuse. But as we safety plan with folks, we can facilitate the appropriate use of those crisis services. And finally, most importantly, it reduces suicidal behavior. So what do we do? So we can keep it simple. And it seems to work best if it's handwritten. Safety plan is handwritten on a 3x5 index card. These pre-printed handouts that you see emergency rooms giving, they can make people actually feel more hopeless. Like, especially if they're left to fill it out by themselves, like as a checklist to discharge, they may hand it back with a lot of holes on the safety plan, which is nothing more than a glaring reminder of how isolated and lonely they are. And from oftentimes from our perspective, we're like, okay, they turned in the safety plan, we can discharge them now. And it can be kind of routine and rote, versus we have to remember, like, we're applying intervention here that can help someone reduce their emotional distress. The last thing we want to do is make them feel more isolated or lonely through our intervention. And so if you just have a stack of 3x5 cards in your office, you can do this. Pull it out, hand it to them because you want them to write it. Now, here are the key steps for a simple safety plan. Number one, get the narrative. So be very specific with the questions to get the narrative. So if, for example, we're working with someone who is suicidal in that moment, would you be willing to tell me the story that got you here tonight to this place of suicidal thinking? Or if we're working with someone who attempted suicide and they're now, in the emergency room or in a stable place, would you be willing to tell me the story of your suicide attempt? And then listen for the patterns that lead to the crisis. And then really the best maneuver then is just keep asking, what happened next? And then what happened? What happened next? What did you say to yourself then? What were you feeling at this point? Back to that be curious principle of listening. Just, be the reporter who's wants to get the minute to minute activity of what happened in their head and their behaviors. And there's the power, the psychology of safety planning. As they talk about it, the suicidal pressure comes down. So that right there is the best medicine, because then they're able to feel less suicidal pressure. The risk of acting on the suicide has gone down. And remember, it does not take long. 5 minutes, the 5-minute rule. You can do it in the ER, you can do it in primary care. It's not going to set the rest of your patients in the day back. You give them 5 minutes to get the narrative. Then you identify with them, okay, what are the warning signs? What are the warning signs that you notice inside yourself that lead to these suicidal thoughts or this suicidal planning? Or how do we know when you're heading down this road? And on the 3x5 card, they're going to be writing down their warning signs. I think some people call them like triggers. And someone pointed out to me once that like trigger is not the best word to have on your your safety plan because of the implication for a gun. And so that's again just something to be mindful of. I don't think you have to be too careful, but if they use the word trigger, I use the word trigger. Otherwise, it's usually like warning signs. After warning signs on that 3x5 card, you want to identify the coping strategies. How are they going to manage to get through the crisis? What works? What works? And you can ask, what works for you? What's worked for you in the past to get through this? Is it holding ice? Is it clenching your fists? What works for you that's healthy? And right here, you'll probably get a lot of people that are unable to identify, well, I don't have anything that works. That's why I'm here in this. And they'll say a lot of language because they're so upset and mad and you're not being sensitive. And so being sensitive to the fact that sometimes they won't be able to fill it out, that's where we brainstorm together with them. What would you like to develop as a coping strategy that could work for you? And brainstorming with them. I love the holding ice because it's a little bit painful, just a little bit painful, but it's nothing like cutting, right? You're not going to leave, you're not going to draw blood. You're not going to leave tissue damage unless they're holding dry ice, which I never recommend, but just ice and holding ice. And then after that, if it's appropriate and you feel comfortable, you can talk about reasons for living. Now that you see that in a lot of safety planning, like webinars or trainings, I find that kind of hard in safety planning because it's kind of like, if someone came in with an open chest wound, they're bleeding, they have priorities to attend to with that wound. And if the ER doc came in and is like, hey, so what do you want to be doing in 4 to 6 months? It seems off to ask someone with an open chest wound, like, what's your plan 4 to 6 months from now? And I think that can kind of sometimes apply with someone in a suicidal crisis when we are trying to find reasons for living. It can come across as very insensitive because in that moment we have to remember they don't want to live. So asking someone for reasons to live is kind of more salt in the wound. Like their goal is to not be alive. And so we have to be mindful and sensitive of that state of mind. So if it's appropriate, you can pull that up, but I think we have to be very cautious with that in safety planning. And then finally, the last thing is identify supports and access to emergency services. So when you're stressed, who helps take your mind off these things, or who can cheer you up, or who provides support in a tough time? And if they can't think of someone, you can just suggest someone, and try to normalize. It's okay, it's common, but this is something we can work on together with your safety plan, and you can move on and talk about the 988 crisis line. Now, I'm a big proponent of the 988 crisis line. On a safety plan, everyone should know about it. And I've found a really cool application of this in the safety plan by inviting people to go through a rehearsal and call the 988 line when they're not in crisis. And when they do that, it helps them feel more comfortable to call it when they are in crisis because they hear the human on the other end. They're just saying like, look, I'm not in crisis right now, but my doctor told me to just practice calling you guys and see what it was like. Once they've gone through it once, there's less of a barrier to actually use the line when they are in crisis. So that's
do you
something
have them do that with you right then, or just tell them to do it sometime?
I just tell them to do it at home when they go home.
Mm-hmm.
When you go home, I want you to practice calling the crisis line. We can talk about it at our next visit.
That's great advice.
And I think it fits in line with what we do with, like our fire escape plans at home. Like we run through the drills with our kids.
Yeah.
And they end up having like nightmares that night because I made them go through the drill. But we still do it. So, then you can just close up the safety plan or the crisis plan by like so what do you think about this? Like any problems to this plan, or and try to get more perspective from them on how that safety plan is. Then they can fold it up, put it in their purse or wallet. It's not as easy to lose as a piece of paper. Sometimes these apps, they're good, but it's kind of unwieldy when you're in a state of crisis. Like, to find the app in your phone and to be looking at your phone can sometimes be so distressful, versus like, I remember I have that card here in my wallet. I'm just gonna pull it out and look at it. So it's just sometimes even that old technology of pen and paper on a little card can move the needle for folks. So another day, another time, we could talk about counseling on access to lethal means like firearms. I think that's so crucial to a safety plan. But I thought for this, episode right now, we could just go over the structure of the safety plan at this point in time.
Oh, yeah. Thank you for doing that. That's so helpful. And I had a question really quickly, though, before we defer that topic to another day about access to lethal means. When you are taking a routine history, so it's not necessarily a crisis situation, and especially a psychiatric crisis, like I was doing an OTP intake today for a patient who I actually know very well, but we're transitioning her into OTP for more support. And so I was going through a suicide screening, and I didn't know if when I was documenting afterwards, I had not asked her about access to firearms. And I was thinking, should I do that for everybody, even if it's not like an imminent risk or something that is part of kind of their chief complaint?
So if I'm hearing you correct, um, is the question, should I be inquiring about access to firearms, even if they're very low risk of suicide?
Exactly. Although now, I mean, from what you said today, everyone, with this active substance use disorder it's not if, it's how much. So that's something to really take to heart. But yeah, I guess the question is, and I should know the answer to this, but globally, do we ask about access to firearms for every single person that we encounter in addiction, psychiatry and addiction medicine?
I think so, Paula, because of that theory, that I hold, that suicidal thoughts at some point are a part of their experience, and if it's wrapped in with wearing your seatbelt and wearing a helmet when you ride your bike, you can pitch it as like a measure of compassion and self-love and self-care. Like a lot of times in our, just some phrases I use, like a lot of times when we're in our addictions, we really don't self-care anymore. And we stop wearing our seatbelts when we drive. We stop wearing our helmets when we are riding our bikes. And we don't really pay attention to our firearms being stored safely. Sometimes we keep the ammo close to the firearm, the ammunition close to the firearm. How is that experience with you, with your firearms and ammunition, with your seatbelts and with your helmet? And then you can kind of leave it open to where they'll go with this. So then you're not just isolating the firearms as like its own particular stigmatized issue.
And that's really helpful. Thank you.
And that's another thing from a safety standpoint. And maybe you both have observed this too. People stop wearing their seatbelts deep into addiction. The more you ask about that, the more you'll find that like they would be grateful if the car would hit them to stop this insanity and like this suffering. And so, and if you find that that's true and they share that with you, that can be a part of the wellness plan. Is, you buckling up every time really does show great progress. Like, that's awesome. Good job. And so glad that you're starting to self-love more and more, that you'll buckle up.
Yeah, wow. I need to start talking to people about that because I see them whipping into the parking lot all the time. And it's actually, you're making me think so much, but taking care of an incarcerated population over the last couple of years has taught me so much. And the level of suicidality and hopelessness in that population is pretty profound, as you both know. But I've been really alarmed at how much passive thinking like that there is in that population, like death by police, death by law enforcement is such, I didn't even know what it was. I had to go home and look it up. So yeah, that's really relevant, and I need to make some changes to my practice to talk more about safety. And so thank you for reminding me of that.
No, I appreciate both of you and your humility to listen, and to invite me to talk about these things, because, and I always fear that I come across as like I know it all, and it's really the opposite. I feel like I don't know enough, and that's why I was really excited to hop on with you for this episode, was to keep reviewing these principles and these concepts and these treatment interventions that I want to continue to apply day to day. Because even though I talked about it, tonight with you, I'll probably really mess up the safety plan tomorrow with someone, and I'll feel powerless. But I think it's an iterative process for all of us. And as long as we're talking about it and reflecting on it together and in our field, we can continue to share, the theories and the evidence and the stories that are working, and then what didn't work, and talking about the unfortunate outcomes and maybe what we missed, so that we can better help, the people that we're going to meet in the future.
Thank you so much. I feel really motivated and uplifted by the conversation in general. And I think our listeners will really benefit from it. I know this will be an episode I will go back and listen to over and over again. And I took some notes. I listened for the first couple of minutes, though, and then I started taking notes because I wanted to remind myself of some of your points. So thank you so much. It was really, really excellent. And it's going to be wonderful to share this on the podcast with our listeners from all over the country and even all over the world. So thank you so much.
Yes, thank you so much, Spencer. I'm excited to do my homework.
Darlene and I can practice because we talk to each other a lot, so we can remind ourselves if we're head nodding too much or if we're documenting how we're doing with our safety planning.
Well, I am just very honored. I look at you two as, just superstars, and you don't know how much I appreciate the work you do. So I'll just try and say, I really appreciate the work that you're doing, both, just in the clinic and on the podcast, and just overall.
Thank you so much, Spencer. And thank you for your time. This was fantastic. Until next time. Hey, check us out at theaddictionfiles.com or email us at theaddictionfiles@gmail.com. Thank you so much to Ricky Valades for use of his song Awake. Check him out at rickyvalades.com.
Are for entertainment and education purposes only. Hosts and guests are not responsible for any harm caused by information obtained from this source. As each person is unique, you're advised to seek the advice of your own healthcare professional to treat any medical conditions you may be having. Opinions expressed on this show are those of the Addiction Files and not of our respective employers.